Okay, thank you.
Okay, we'll go ahead and call the meeting to order. Do we have a quorum? Make
Yes,
sure
we do.
we have one? We're good? Excellent. So welcome everyone to the May meeting for the Medical Advisory Committee. We'll go ahead and start off with introductions, and I'll go ahead and start with myself. I'm Dr. Burley, EMS Medical Director for the EMS agency.
Teresa Rios, EMS Director.
Jeff DeAndrea, EMS Analyst.
Deb Hopgood, EMS Analyst.
Kimberly Hernandez, EMS Analyst.
Steve Brooks, EMS Analyst.
On Zoom, this is Roxanne, EMS epidemiologist. Forgot my position there.
Tina Nieto, Law Chiefs.
Will Hiller, AMR CES.
Cole Click, Natividad Medical Center.
Morning, Jeff Horner, Program Director with CalSTAR.
Derek Orchard from Natividad Medical Center as well. Silas Fisher from Monterey Fire Department.
Dave Craddock, paramedic.
Michelle Kalinsky, Chomp.
Roger Reinhardt, CAL FIRE EMS.
Is that everyone? Okay, perfect. Well, again, welcome. Thank you for being here. And we'll go ahead and move on with the first item on the agenda, which is public comment. Any member of the public may address the subcommittee for a period not to exceed 3 minutes on any issue not on the subcommittee's agenda. And MAC will listen to all communications, but may not take any actions. Any specific public comment? Okay, hearing none, I'll move on to the next item on the agenda, which is approval of past MAC meeting minutes. You should have the minutes from our past meeting, and hopefully you've had a chance to take a look at
I want to
those.
say it's like 10 minutes by Brown. It's like paramedic discretion.
Just make sure that
Could be
your mic,
confusing.
just make sure your mic is off because we have an open mic on. I think it might be you, Roger.
Yeah.
But I mean, that's a good ballpark. I mean,
Mhm.
yeah,
We could get a motion for approval.
Yeah, it's Michelle Kalinsky. I'll motion to approve.
Thank you. Do we have a second?
Jeff Horner, I'll second.
Thank you. So given that this is primarily Zoom, we'll go ahead and take a roll call for approval. So can we do a roll call for approval?
Michelle Kalinsky.
I don't think they can hear.
I don't know if they can hear you. So Dr. Kalinsky,
Approve.
approve.
Dr. Click.
Dr.
Approve.
Click,
Approve.
Christy Soboleski.
Christy. Christy Soboleski. Are you with us, Christy? Okay, let's move on to the next person.
Dave Craddock.
Approve.
Thank you.
Derek Orchard.
Approve.
Jeff Horner.
He already voted.
Jeff,
Approve.
thank you.
Hey, I'm sorry, I walked away. This is Tina Nieto. I approved the minutes also, so.
Thank you, Tina.
And
Will Hiller.
Will Hiller.
Did you call me? Sorry, I could
Yes.
barely hear you. Sorry, I approve. My apologies.
We have everyone?
Yes.
Okay, thank you. Sorry, it's a bit awkward sometimes over Zoom, but appreciate the approval of those minutes. And that brings us to our next item on the agenda, which is EMS Week. Do we have someone like to talk about that?
Happy EMS Week, everyone.
All right.
Yeah, we just want to truly thank all the EMS providers from first responders, EMTs, paramedics, nurses, ED staff, and all the people who truly make our EMS system wonderful. I want to thank you all for your service.
Thank you, Steve. And once again, happy EMS Week. We truly appreciate everything that you do. And thank you for making such a meaningful difference in the system and in the lives of the patients that you take care of.
I'd like to echo what has just been said. It is a privilege to work for this system. I am proud to serve this system and to work continually to move it forward along with our team members. And thanks to your contribution, our partners in this.
Thanks, Teresa. Okay, well, excellent. We'll go ahead and move on to the next item, which is correspondence. I do not believe we have any specific correspondence, and that would then bring us to reports and EMS agency updates with Teresa Rios.
Thank you, Dr. Burley. We want to report that we are continuing to work with Human Resources to fill the health program coordinator position. We are working to execute a number of new agreements or extensions to the current agreements so that we can be more efficient in our data collection, analysis, and reporting. Our MOU for the trauma center was set to expire this June. So we already have the wheels in motion, getting a new MOU in place. We also have the ball rolling on the trauma registry, Get With the Guidelines and CARES. And I know these are contracts that were overdue for different reasons. We had hit some issues trying to execute those, but they are gaining traction. And so we hope perhaps by the next meeting to be able to report that those are executed. In our ongoing effort to improve our system, we have been taking a fresh look at everything that we do. As you will hear from reports that will be provided by staff, the EMS agency is working on projects to move the system forward. I'm not going to go into detail about those. You will hear those from our staff. And again, I want to thank you for all of your contribution when you reach out to us and you let us know what's going on out in the field, or voice some concerns that you may have or ideas that you may have. It shows that we are working as partners. So I appreciate that.
Thank you, Teresa. And so that brings us to old business. And the first item on the agenda for old business is EMS agency response to COVID. And Jeff, you have an update for us?
Yeah, podium. Good morning, everybody. The EMS response to COVID, one of the primary vehicles for that is through the MOHAC program. And compared to previous committee meetings, the MOHAC activity has decreased over the last 2 months, directly in relation to decreased demands
for COVID response. The Mohawk program still is distributing PPE to stakeholders and healthcare providers throughout the county. The volume that we're seeing has certainly decreased. And we've moved into a little bit of needles, syringes, sharps containers, supporting some vaccine clinics in sort of as an alternative activity. Right now, we're seeing still some demands for a few items, gloves, for example, visors, some things that are hard to get or expensive in the private market. Otherwise, more or less status quo with decreased volume. That's really the only update, is just that we're continuing to operate as long as the emergency is declared. PPE will be available through the program. And then my other bullet point in the agenda is just sort of to acknowledge everybody, because Monterey County has done a great job with the vaccine deployment. We had some stutters in the initial weeks, as probably every county did. But we've done a great job. We're keeping pace with the rest of the state in terms of numbers and percentages of people that are partially or fully vaccinated. And that has happened because there's been hospitals, clinics, fire departments, the agency, ourselves here, and we've had all kinds of cooperation and new arrangements and collaborations have taken place that haven't before between organizations that have not worked together in the past. So I wanted to acknowledge that, and that everyone's done a great job. And as far as the Mohawk role, hopefully the trend continues, and the weeks of the emergency declaration are counting down, and we are standing ready to help fire agencies with fire season, which is promising to be just as severe as last year. So, any questions?
I just want to take a moment, Jeff, to acknowledge the role that you've played as well in the pandemic response, particularly with Mohawk and distribution of PPE and all the things that went into that. I know that was sort of kind of a make or break situation, and you really stepped up, and the program worked. And so I just want to acknowledge your role in that and our appreciation.
Thank you. I appreciate the acknowledgement, and just have to say that I succeeded again through all kinds of partnerships and logistics and Cal OES, and everybody that I've worked with has been really responsive and great. So thank you. Appreciate it.
Okay, well, that brings us to the next item under old business, which is policy and protocol development cycle for July 1, 2021 effective date. And Steve Brooks has a report for us.
Good morning. And this last meeting, we talked about the policies and protocols that we moved forward with the regular cycle, and we've distributed these policies in training format. They're complete except for signatures, and we've distributed the training materials with them. And so we're expecting everybody to have their personnel trained and ready to go for July 1, as well as any equipment. Mag sulfate is one that comes to mind that's new for this cycle. So we expect that to all be ready to go July 1. And if anybody has issues, problems, concerns, then they should certainly reach out to the EMS agency, and we can help facilitate or work through. That's really all I have. It's just a report to say that we've moved that forward, and happy to have done so. And are there any questions at this point? Thank you very much.
The next item, Steve, is protocol revisions off cycle. And I'll let you go ahead and take that as well.
Well, good morning again. As far as the off-cycle policy and protocol revisions, the off-cycle ones are ones that were brought to our attention through the QI committee, and really were just some corrections and small updates that needed to be made. And we've probably talked about moving it forward through a regular cycle. It didn't seem to make sense when we're really just making corrections. So at this point, we're bringing some pediatric policies, or excuse me, pediatric protocols. the CP2 cardiac arrest, VFib, pulses, VTAC, the CP3 tachycardia with pulses pediatric, CP4 bradycardia pediatric, EP5 overdose and poisoning pediatric, and MP3 pain control pediatric. We would love to have this group endorse the corrections that we've made, and we'll have them also ready for July 1. And they have been distributed with the regular policy cycle update so that the training can begin on those and everybody can be assured of being noticed on what the corrections were. So that's the EMS agency is asking this committee if they would endorse these policy or protocol updates.
Hey, Steve, it's Michelle Kalinsky.
Yes, ma'am.
As I was reading through them, I would like to see if we could just kind of clarify a few things. One is it's always nice to have a max dosing on peds, which I don't see in a lot of areas and I do see in others. When we list that max dosing for like the amiodarone under VFib, it's a single dose not to exceed 300 milligrams. So if that can be specified, because it kind of leaves it a little bit ambiguous in that. And then just for consistency on your, like on the tachycardia with pulses, you list the AHA guidelines for cardioversion, but they're not listed under VFib, VTAC. So it might be nice to be consistent and list them in both areas. And then I think one other thing in the tachycardia with pulses is I still have concerns about having to make base contact for an unstable patient and have that delay. I think if you've got an unstable, wide complex or narrow complex tachycardia, you probably should just proceed with AHA guidelines and not wait for base contact, in my opinion. But that's just a small concern for that one. And then I guess the only other thing for the bradycardia policy is I know PALS kind of defines the heart rate, and we don't. So a bradycardic infant can have a pretty high heart rate. And do we want to stay consistent with PALS and define that heart rate at what point you're going to start your compressions?
Okay, yeah, I think that's reasonable for us to look into that and defining pediatric bradycardia and the point at which compressions would be indicated and we can reference PALS for that. Do you have the other corrections that Dr. Kalinsky went through, Steve? Did you? I noticed you weren't writing things down, and I don't want to miss some of these things. So
Okay, let me go through the things that I did capture. So for CP2, would like to have the AHA guidelines and then some additional information regarding amiodarone.
Max dosing as well for things like epinephrine, lidocaine. I think pediatrics always having that maximum dosing is kind of key because in the heat of the moment, I think sometimes people don't think about that.
Okay. All right, so that's what I have for CP2, the cardiac arrest. For tachycardia with pulses, I didn't catch anything that you wanted, but I will look for max dosing, make sure that that's there.
So I think one of the keys with tachycardia with pulses is right now you're requiring base contact for unstable patients in need of cardioversion. And I think that it would be optimal in an unstable patient to allow you guys to follow the PALS and AHA guidelines and cardiovert.
So base contact after cardioversion.
Well, I just think you probably shouldn't wait in an unstable case.
right, and I guess the rationale there was to make sure that cardioversion was clinically indicated. You know, there's some judgment there when you have a tachycardic patient, whether this is a physiologic response to an underlying condition or whether this is a true cardiogenic tachycardia. And so I think that was the rationale for putting base consultation prior to cardioversion to make sure that it's clinically indicated, because it's fairly rare the need to cardiovert a child. And oftentimes there's an underlying medical condition there that would be more appropriately addressed. I just want to make sure that, you know, there's the opportunity for guidance if it's unclear or if the EMS personnel are not completely convinced that cardioversion is necessary.
I would agree that base contact should be made if they're not convinced that it's necessary. But if, you know, I also agree it's very rare, but you know, if you've got a congenital heart kid sitting there with a super fast SVT that's unstable, or, you know, very rarely a wide complex VTAC, and it's not cleared with adenosine, you probably need to treat them rather than wait for a base consult, which can be, you know, you can deteriorate in that time frame that you're waiting for your online control. I would say though, you know, just looking at things like this, making early medical control or early medical contact with the base physician certainly is appropriate. My one concern would be, does Natividad have the ability to receive EKGs? I don't know that they do, since they're not a STEMI center. So it's one of those where it's kind of hard to guide when you don't know what you're looking at as a base physician as well.
We do not have the ability, to my knowledge, to get the EKGs currently.
Right. So that would be one thing to consider if you're looking for us to diagnose what the rhythm is. But basically, I think my decision on this is, if you know that you have a tachydysrhythmia that is not sinus tach, and this dysrhythmia is causing the patient to be unstable, we should stick with PALS.
Okay.
All right, so I've got a note to move base contact below the cardioversion on tachycardic pulses with CP4 bradycardia pediatric. We'll define the heart rates to be considered for age ranges for bradycardia. Any?
Right. And then the only other thing on your overdose is, I think your minimum stock on glucagon is 3 milligrams. And you've got a pretty low dose for your overdose patients. I don't know if you want to go weight-based dosing on that and allow for higher dosing, which is usually more effective in the setting you're using it.
So for beta blocker overdose, talking glucagon?
Right. So your minimum stock, I think you guys have up to 3 mgs, and the dosing can be weight-based in peds. You usually run a much higher dose of glucagon to reverse these overdoses. So you may want to just utilize that weight-based dosing.
Okay. Oh, Dr. Quick has a question.
Oh, I just wanted to say, I agree with you, Michelle, on the idea to just use PALS. I think it kind of like we follow general ATLS protocols until somebody gets into the hospital. Once somebody's at the hospital, sometimes we will depart from those if we can offer a higher level of care. But I think it makes a lot of sense to follow PALS until the patient makes it to the hospital. And at that point, if we want to depart from the PALS algorithms, I think that's probably an easier time to do it.
Okay.
Great, thank you.
So I'll come back to the group with these recommended revisions. Would the group like to endorse these policies?
I would endorse with the revisions as outlined.
Thank you.
Second that, Cole Click.
You want to do a roll call again?
You have the list.
Yeah.
Dr. Orchard?
Dr. Orchard? Or Miss?
No, Dr. Click.
Dr. Click.
Oh,
sorry.
Dr. Click. Okay,
So
sorry.
Dr. Click and Dr. Kalinsky have endorsed, right?
Okay.
So we can,
Dr. Greenson?
She's not here.
Okay. Jeremy Hadlin?
I don't think Jeremy's with us.
David Craddock?
David?
Approve or endorse, I guess. Sorry.
Will Hiller?
Will?
I approve.
Jeff Horner?
Aye.
Chief Nieto?
Aye.
That's everyone I have.
Great. Thank you.
Okay, well, perfect. We'll That'll bring us on to the next item on the agenda, which is addition of ketamine for pain management. As you know, during our meetings 2 months ago, we discussed the opportunity to bring ketamine into our pain management arsenal. And so the agency has taken a look at that, reviewed some of the protocols that are utilized by surrounding counties and other LEMSs within the state, taking a look at some of the evidence-based protocols and had come up with a proposal for ketamine dosing in both adults and pediatric patients that we presented to CQI TAG and TQIC yesterday. We had pretty good discussion. A couple items just to sort of hit on. And Steve, can we pull up our protocol with the 100 cc?
If I can share my screen.
Yeah.
Good. So this is the protocol.
Great.
That has.
So here is the adult protocol for pain management. And as you can see, what we have here, I think this is the one with, do you have the other one?
Yes, it's coming.
Perfect.
It's the one up on top now
Okay,
with.
go ahead and pull that down there. There we go. Perfect. So as you can see, we have a weight-based dosing for analgesia for adults of 0.3 mg per kg. There was some discussion yesterday. There's different options for administration. You can administer this medication as a slow IV push administration, or you can mix it in a bag of 100 milliliters of normal saline and administer over the course of a couple minutes. In general, it was felt among the group, and I agree that mixing the medication in a 100 cc bag and running it in over about 5 minutes would be a safer way to administer, just to prevent rapid IV push, which can have some adverse effects. And so that's the protocol that we have in front of you here. There will be a max dose of 30 milligrams and an opportunity to repeat a dose in 10 minutes following the initial administration. Can you go down a bit there, Steve? We have.
Absolutely.
So that's the policy that we have thus far for adult administration. Any other comments on that or discussion on that?
Yeah, it's Michelle Klinsky. I know yesterday you briefly discussed that you had multiple agencies that weren't carrying both agents in terms of morphine and fentanyl, and that this was there to allow another option. I'm just wondering, do we really need to carry both morphine and fentanyl? I mean, I think fentanyl has a pretty robust literature in the pre-hospital setting. Is definitely the preferred opiate for most things that we use opiates for, mainly trauma. And it just seems like if you've already got agencies that aren't meeting their minimum stock, why would we not consider optimizing things so they don't have those expenses, especially as we consider adding on something like ketamine as an adjunct? And then my second comment would be, if Steve were to scroll up, you list morphine or fentanyl or ketamine. And I think while we can't design a policy to meet every single criteria, we can optimize things. And knowing that ketamine and an opiate truly does decrease your opiate requirements and they can be used together, that or probably should be something and or, where if you need a second agent, you can use it. And then I do think we should have some notation where ketamine is the preferred agent in patients that are highly dependent upon opiates or on bupe, and probably not the preferred agents in somebody on stimulants or so. Those would be the only comments for the adult policy.
Yeah, and to address your first point, we have taken a look at whether it's reasonable to continue to require both morphine and fentanyl on minimum stock. And we've made a decision to loosen that requirement such that agencies can carry either medication. As you say, fentanyl oftentimes is more advantageous for various reasons. And so, you know, agencies that are carrying only fentanyl and are no longer carrying morphine would be back in compliance with our minimum stock requirements.
Has there been any thought to just moving preferentially? I mean, I don't know really why we would prefer to use morphine or incur the costs or not have fentanyl. Is there a shortage or something where we want to have both?
I don't know, I'll open that up to discussion. Anyone else have any thoughts or
I think it makes sense to at least have the policy flexible for both, whether or not the agencies always stock both on the ambulance, just because that there are drug shortages from time to time. That way you don't have to rewrite the policy or the protocol if there's a shortage on, you know, vials of fentanyl, or if there's a shortage on vials of morphine. It makes it pretty seamless to transition between the two. But I think either one is a reasonable drug to give a patient in pain. Fentanyl is fewer people probably have adverse reactions to fentanyl, so it might make it simpler, and it doesn't last as long should the patient have an issue after its administration. But I think either one is fine, just as long as the policy allows flexibility for in the future if there is a drug shortage or one agency is out of one medication but has the other.
This is Roger Reinhardt with CAL FIRE. I would convey what Dr. Click was just saying. It is nice to have the flexibility of either or. We have run into shortages in the past, and accessibility to one or the other medication has been difficult. So I think at least keeping the option on the table for the agencies to be able to buy one or the other is preferential.
That sounds great then. So do we have a change in the minimum stock policy that's going to go in place as well, since we know that people aren't able to meet that?
Yes.
It was distributed and will be effective July 1.
Any other discussions, questions, concerns regarding adult ketamine dosing here?
So one thing I would say is, I mean, it's kind of hard when you're doing an infusion and you don't have a pump to put things over a specific time frame. So I don't know if you want to make it more vague. I don't know how your medics are going to gauge this to exactly 5 minutes when they're busy doing other things in the back of it. I think the point is just go slow so you have less adverse effects.
I actually agree with that as well. I think it's a little bit overly restrictive. There's other ways to make sure you give it slow, like mixing it with the 10 cc saline flush, and then you have a little bit more volume to slow push. I think there's many medications that they're practiced with giving slowly, and it's just so difficult to arrange all of the dooming.
This is Will Hiller from, Will Hiller from AMR. Regarding the minimum stock policy, due to limitations in getting the medications, like sometimes you can't get morphine, should and or be listed with each medication, ketamine included.
I think that's reasonable. Although you wouldn't want to use both morphine and fentanyl together, right? You pick one or the other.
Yeah, you probably have or between morphine and fentanyl, and or ketamine.
And I'm also referring to the minimum stock policy too, to allow us to, if we can't get ketamine or can't get fentanyl, we have the and or option there. And I'm saying that it should be on the ketamine side too.
To clarify, Will, you're suggesting that minimum stock should reflect morphine and or fentanyl and or ketamine such that agencies could stock any of the three?
Yes, sir. Especially if there's difficulties getting stock of any of the three. We have the and or option for morphine and fentanyl because of that. And I would like to see it for ketamine also.
Could that be misconstrued though, so that somebody thinks they don't need to stock an opiate at all?
Right.
That'd be the.
I think I've been, I don't know, any comments regarding that proposal?
I think it makes sense that you have at least one opiate and that ketamine is an alternative or an alternate drug if you have the right patient that shouldn't either have an opiate or the opiates aren't effective. But I think that probably it should say in some way that you have at least opiates in addition to the ketamine and not just stocking ketamine at this point.
So you want us to look something like that?
What do you have here, Steve? Just
This is the authorized stock policy that was distributed for training and will be in effect July 1.
I'm sorry, I'm not seeing the ketamine on there. Is there?
That's because ketamine's not in effect yet.
So yeah, Steve has just put in parentheses the and or morphine or and or fentanyl, giving
Okay.
the opportunity to carry one or the other. And I agree. I think, you know, it's important to have some tools at your disposal and not just have one hammer that addresses all issues. And there's certain, and I don't want folks to kind of end up getting pigeonholed into having to administer ketamine because there's nothing else. So I think having one or the other, fentanyl or morphine, would be appropriate. But we'd like agencies that at least carry one narcotic. And then I think if you know, we 2 months ago when we brought this to the table and discussed pricing, we found that stocking ketamine was fairly inexpensive and there were no real objections to introducing it from a financial standpoint. So I think if we're going to introduce it, I think we should have it on our rigs and not have, you know, some units using it, some units not using it. It just becomes fairly messy. And given that there's not really a financial constraint to it, I think we should, if we decide to move forward with ketamine, we should have it on our minimum stock and then allow for some looseness as far as whether to carry fentanyl or morphine. Any other comments thus far? And then I'll go into pediatrics and in the next discussion here.
If I may, Dr. Burley.
Yeah.
Also, for the group pre-hospital folks to note, we did increase the amount of morphine and fentanyl to be carried by the non-transport ALS providers because the amount that we had of 2 was inadequate to fully meet the pain management and pain control policy and protocol. So we had to bump that up 1. Just to note.
Thanks. So let's move on to move the discussion on to pediatric administration of ketamine. We had a pretty good discussion yesterday regarding pros and cons of pediatric administration. The concern raised by Dr. Kalinsky was that, you know, there is a rare potential adverse effect of laryngospasm with ketamine, and while we can intubate our adults if push comes to shove, you know, our paramedics are not authorized for pediatric intubation, and so if they get themselves in a situation in which the patient has a persistent laryngospasm, there could be trouble. And so I guess I'd just like to kind of open the discussion up a bit here and hear from folks as far as thoughts on pediatric administration.
Michelle Kalinsky.
Yeah, so I think that the laryngospasm is a minimal, very rare concern that I was trying to express. I think my bigger concern, honestly, is that there is actually minimal to no evidence base using ketamine in the pre-hospital setting for the age group that we define as pediatrics. And, you know, the trials that were sent to me that were done well, like the Prime JAMA trial, starts at an age of 8. And so I think when you look at this, stuff that we do in the emergency department that we know to be effective may or may not be of benefit or work well in a pre-hospital setting. Pediatric intubation is a classic prime example of that. And I think that when you, as an EMS agency, are instituting something that base hospitals are responsible for, the agency is responsible for, you know, if there's an adverse outcome, we all pay as members of this county, that we need to try to be really evidence-based, or we need to research and look at this. And I don't think, after looking through the evidence last night for an hour, that you really have an evidence base in the pre-hospital setting to show safety of ketamine. And while ketamine is a very safe drug in the hospital, there's things that you don't have, like an accurate weight on the kid. And while, you know, you mentioned that there was a 5-time differential, in actuality, that's not quite accurate, because ketamine is really variable. When you go above that 0.3 per kilo based on the ideal body weight, you can get into an early dissociative state around 0.5, 0.6 in some cases, and you can get into anesthesia induction at 1 per kilo. And that dissociative component isn't ideal to have an agitated kid in the back of a rig. You also, if you look at the studies, many of them show that there's more adverse effects with ketamine than with the opiates. And with an opiate, yes, you can miss dose as well, but you have an antidote in the back of the rig that can fix that. And so I think my point is if we're going to do this, let's get with other LEMSAs and let's run a trial and show that this is effective and get the database we need to say that this is an evidence-based good practice in the pre-hospital setting. And that's all I have to say.
Thank you, Dr. Kalinsky. Any other comments? So I think Dr. Kalinsky raises some good points, and you know, we've had an opportunity to discuss a bit, and you know, this is not something that has to happen. You know, as an emergency. This is a medication we're looking to add for potential benefit when in situations in which patients, you know, narcotics may be contraindicated or less ideal for one reason or another. And so, since there's some concern raised about, you know, young kids getting ketamine in the pre-hospital environment. And you know, I did send over some studies, but you know, there's the literature and experience is not robust in the pre-hospital setting, and so I think it would be fine to hold off on ketamine for peds, particularly our younger pediatric population. I think we define peds as 8 and younger, and so. And so I think that it'll be reasonable to hold off at least for the time being, and then we can kind of take a look at whether a study that you're suggesting would be feasible with other LEMSAs, or you know, maybe perhaps you know, more data comes out over the course of time. So I'd be okay with holding off on peds administration, at least for the time being, unless anyone else has any other comments, thoughts, suggestions?
So there is just so you know, there is a large trial that's currently in progress. It started in 2017. They don't have any of their prelim data out, but you know, maybe they're getting somewhere. There's just so few peds cases that meet criteria in a lot of systems. It's hard to get the numbers.
And so are we okay using ketamine in the pediatric population? Technically not peds according to protocol, but you know, ages 9, 10, 11, 12, you know, older children. Do you still have concern about that population, or would you feel more comfortable with that population?
I feel more comfortable with that population. Most of the studies that are out there did not define this subgroup, and there's still a paucity of any reasonable data in the pre-hospital setting for age less than 18 that's of good quality. I would say that maybe a note that you preferentially, fentanyl has been shown to be very safe in this subgroup and has an intranasal administration as well. And so I would preferentially lean towards an opiate. It's fairly neutral in terms of adverse side effects for hemodynamics. Obviously, you can get respiratory depression if pushed, but at least first dosing, I think it's reasonable to use fentanyl in the age group that we're talking about, that kind of 8 to 18, and then move to ketamine. I'm less worried about this group, honestly, than I am of getting into trouble with a toddler or so.
Right, and we have ability to intubate this age group if necessary in the pre-hospital.
What's the cutoff for intubation?
I think 8. Yeah.
You also have a broader weight for kind of a missed dose of a couple milligrams, and that's where the concern comes in. You know, that 0.5, 0.6 per kilo range for ketamine can really start to dissociate some groups in a lot of the studies. And since you don't have an accurate weight, I think you have a little bit more room as kids get bigger.
Sure. Any other comments, questions, concerns? Okay, well, thank you. I think this is a good discussion, and so we'll go ahead and hold off on the pediatrics for the younger age group, and wait for additional data to come out from the study you mentioned, as well as other LEMSs that are using it in peds, both here in California and elsewhere. And then we can always revisit it later if the data is supporting the administration, or if we decide to move forward. So appreciate your input on that. Unless there are any other comments or questions, I'll go ahead and move on to the next item on the agenda, which is law enforcement requests related to blood glucose, jail, and medical checks. And again, we had a pretty good discussion on this yesterday with our committees, CQI TAG and TQIC, and you know, I know that this is an issue that EMS struggles with, not just here in Monterey County, but throughout the state and throughout the country. You know, quite frankly, sometimes we struggle with it in the emergency department too. But so it's a fairly universal problem. And so kind of, you know, in our discussions, we had looked at whether there's some kind of you know, algorithm, or whether there's some sort of checklist that could be utilized to sort of categorize what patients might not need medical clearance and could go straight to jail, or what patients might need to be taken to the emergency department. Deborah was kind enough to offer a suggestion based on her experience from her prior practice in Colorado, in which they're using a checklist that that helps to delineate that. And so I wonder if we can kind of, if we have that, we can put that up on the board. Not that one, it would be the There's like, should be a checklist there for,
Yeah, there you go.
there we go. So Deborah, do you want to maybe just talk briefly about your experience and this particular checklist?
Sure. This particular checklist is related to more to the disposition of intoxicated parties portion up there, but we were having similar issues with some interactions between law enforcement and then our sobering centers / detox facilities, EMS, and jail staff as well. And this came about as a way to address this. And what we did is we met with our detox facility within the county, looked at their criteria for admission, looked at what was a reasonable assessment for EMS to conduct, met with law enforcement, and kind of after we had combined that information and updated them on, what we had found would be a reasonable patient to send directly to a detox facility rather than to the emergency department. And we formulated this checklist here that our field crews could use to document their assessment. This was made in our instance in a duplicate form. The EMS crew would fill it out. It could be filled out by either a BLS crew or an ALS crew based on how the assessment was designed. And then they would fill this out, they would sign off on it, and then they would give the officer a copy of the form. And in our instance, the officer was transporting the patients to the detox facility, and then they would be able to either keep that form for their own records or relay a copy to the detox facility so they knew exactly what criteria the patient had met in the field. And I think, just the process of getting together and having everybody get on the same page as far as what was a patient who qualified to go to, sort of a non-traditional destination was, really helpful. And it just sort of helped resolve and head off a lot of the conflicts that might come up about, questions of assessment or who was clear to go where or what. And we found it a very helpful process. It was utilized very regularly, especially working in a college town, as you might imagine.
Thank you, Deborah. And yeah, I mean, I think it's a great tool that could be utilized, particularly for, intoxicated patients, and really kind of delineates a lot of the decision making so that it's clear, why you're saying the patient can go to someplace other than an emergency department, and also helps to protect the pre-hospital providers as well. Any comments specifically on this checklist?
And I should add too that this checklist is based off a journal published study done by the AMR operations and Colorado Springs Fire Department down in Colorado Springs, Colorado. So it wasn't just sort of a pulled out of thin air list. There was some evidence base to it.
Fisher has a comment.
Hi, this is Tina. I just want to say I support this, not from the area, but when I worked with LAPD, we had something very similar, obviously, because we were dealing with a lot of numbers, and anything that it enables the officers to finish, what they're doing and clear up the EMS workers will be helpful, because as you guys know, on these suspects, a lot of time is tied up with them making all different claims. Not to say they're not true, but they make a lot of claims.
I agree. I think this is a really good idea and nice thing to add to our county EMS and policies.
Silas Fisher.
Silas, do you have a comment?
Yeah, hi, this is Silas of Monterey. Hey, so I had originally proposed this discussion, and it was based on, I would categorize it as probably 100 instances where we end up having disagreements with either transport EMS or law enforcement, or we all, nobody can come up with a good consensus. So I think this absolutely covers what I was looking for, and it would really, to put it black and white. So I really appreciate that. And I apologize, I missed the meetings yesterday. I was in an all-day training. Were we able to touch anything on the aspect of jail check? Or, for example, if a law enforcement officer has to use force to take somebody down, and they want that person checked for injuries, that's also a gray area. Was there any discussion on that?
Right. So there was a discussion, and I think it's a little complicated in that again it's difficult to write a protocol for every instance. Sometimes this comes down to judgment by the pre-hospital staff whether the patient would need to go to the emergency department. Certainly any deformities, any concern for fractures, head injury, altered mental status, unstable vital signs. These are fairly obvious reasons to bring the patient to the emergency department. Things like, abrasions or a small bruise probably don't need to come to the emergency department. And so, you kind of have things on both ends of the spectrum. And it's always the middle area that's the most challenging. In general, I would say that if you have a patient in that middle ground and you're not certain whether it's appropriate or not, those are patients that probably should come to the emergency department to be evaluated. If they don't have any injuries or conditions that require anything further from the standpoint of emergency medicine, we can dispose of those patients fairly quickly. But it's always kind of better to err on the side of if you're uncertain to bring them in for an evaluation rather than miss a fracture or an injury or a significant head injury. We also discussed the getting the input from the medical staff at the jail, because oftentimes they have very specific concerns or requirements on their end, and the reason why they're asking us to do medical clearance is because there's things that they're concerned about, and so kind of inviting them into the dialogue I think will be helpful. And so we wanted to do that. Moving forward is to bring someone in from the jail to kind of get their perspective and input into this as well. So those were some of the things that we touched on at the meetings yesterday, and that's kind of where we are at the moment.
Yeah, I think that's great. And to muddy it just a slight bit more, from a documentation standpoint, if PD calls because they would like somebody checked, even though they don't have any outward injuries, but they say, oh, well, I had to tackle him and I want to make sure that he's clear. Does that then, are we establishing the patient relationship and we're documenting as an AMA, where that person who doesn't have any complaints or injuries, but you would like us to do a full vital signs assessment and then document it as an AMA, or how would you like that?
Well, an AMA generally is a patient who, you're recommending something for that.
Totally agree.
That decides that they don't want the treatment or transport. It's a little different than evaluating a patient, finding no injuries or concerning medical conditions, finding stable vital signs, and feeling that the patient does not need to be transported. So I wouldn't necessarily condone an AMA for every single patient you assess that doesn't need to be transported. Again, if a patient feels that they need to come to the emergency department to be evaluated, they don't feel well, and you don't see anything outwardly, but they just kind of continue to perseverate that they don't feel well and want to be checked, those patients should come to the ED and be evaluated, because you can't see everything in the field, and you shouldn't, that expectation shouldn't be there for you to kind of, have all the tools that we have in the emergency department. We have a lot of things that you don't have. And so I think it's, if a patient wants to come, bring them. It's always easier, again, for us to dispo them from the ED, and it's safer that way too. So I would, but for those patients who don't want to come, they don't have any injuries, they're totally fine on your exam. I think those patients, you can just document, that you were called to the scene to evaluate the patient. You document your physical exam and your vital signs, and no emergent medical conditions. Patient does not require further assessment in the ED. Patient comfortable with that, advised to recontact you if anything develops. I think that good documentation like that far exceeds the protective power of the AMA. A simple AMA is not the the sort of the be all and end all from protecting yourself from liability. A well-documented chart, just essentially going through the things that I just mentioned, is far more protective and more appropriate as well. So that would be my comments on that.
Yeah, and that satisfies it. ESO has some generic dispositions on our end for how we leave the patient. And I think release to law enforcement is one of those dispositions or something like that. So that works out fine, and I'll pass it along. So I appreciate all those comments. That I'm totally satisfied, and I look forward to continuing the jail check discussion too. So thank you guys.
And you can always make base consult if if somebody gets taken down by law enforcement and you're unsure if you think that they need further evaluation for their injuries. I mean, I think the idea behind this is maybe it cuts out half of the low hanging fruit of these patients don't need a jail check. Some patients still will need them. And if it's a gray area, make base consult or just bring them in and we'll try to get to them as quick as we can. We don't always have a room, but try to get them out as fast as we can. Because I think we'd probably rather see them before they go to jail and then get a call from the jail saying that they have somebody they need to see us.
Yeah,
And
we do. You know what?
This is Tina Nieto. I'm not going to be surprised if we see an increase on these calls from law enforcement, just because of the times that we're in, and it seems lately now too, law enforcement's erring on the side of caution, because if law enforcement doesn't do anything, they go to jail now. So it'll probably go up until it levels out and becomes just the norm.
I would agree with Dr. Click, though, that, if there's any question, it's going to be safer in this subgroup to have them evaluated. So be conservative. These guys hide bad stuff all the time. And this protocol obviously leaves some pretty abnormal vital signs and stuff out there, and a lot of room for error in somebody who doesn't really always have the ability to tell you what's going on. So be conservative.
Thank you, guys.
Excellent. Well, thank you all for that discussion. And I'll go ahead and, for the sake of time, move us along here because I know we still have some other things to cover. The next item on the agenda is interfacility transport using hospital RNs on ambulances instead of CCT. And Steve, you have something there?
Hello again. As far as the topic of utilizing a hospital-based RN instead of CCT has come from the need for some patients to rapidly move them from the emergency department that they're in, again, usually ED, to another facility that's better equipped to handle the needs of the patient. Trauma seems to be the biggest issue as far as the condition of the patient, and to get them to our local trauma center, especially when the patient can't wait for CCT and they have medications or blood products that are outside the scope of the ALS transport unit, the emergency department can send one of their ED nurses, or again, if it's on the floor, a hospital nurse, with the patient to facilitate the administration of blood or other medications that are beyond the paramedic scope of practice. To help facilitate that, to put some parameters on it, to establish common operating procedures. A memo was distributed to the emergency departments, transport providers, to provide some of the guidance on how to make this work seamlessly, so everybody who's involved knows, what is expected. That memo, basically memorializes some things that have been in practice. It's intended, again, to help make sure everything coordinates rather than to prescribe. So it's out there. Discussion so far has been that it hasn't been used unless it's been used in the last day or so. And if there's any questions about the program or concerns, if you've seen the memo and would like to discuss at this forum, we're open to do so at this point. Hearing none, thank you very much.
Thank you, Steve. The next item on the agenda is local optional scope of practice for unified scope of practice for our air ambulance personnel. And you're up for that one as well.
Okay, so as far as this local optional scope of practice, we're in the middle of the process. We've developed a draft policy. We've sent it to the EMS authority for their consideration. And what this really is intended to do is to protect the paramedics who work in multiple jurisdictions. Typically, the helicopter paramedic who may work one day at a base in Santa Cruz County, one day at a base in Monterey, one day at a base in Santa Clara County. And because of the differences in the policies, protocols, authorized treatments and procedures, we have joined with the other counties to create a unified scope of practice so that the paramedic can be relatively assured that if they're going to do a procedure, it's allowed in the county in which they're working, so that they don't have to think about which county they're working in when the patient is in need of care immediately. So this is really about helping the paramedics focus and do the right thing for the patient, and under the guidance of the medical director of the air service as to specifically what treatments they're allowed to provide and what procedures they're allowed to do. At this point, we're still waiting for state approval. Have we heard anything in last day?
No, the next step will be a meeting, the MDAC meeting for Dr.
Yeah.
Burley to present that.
So they've accepted it. We'll go make our presentation and then hopefully get approved, and we can join other Bay Area counties in this local optional scope. At this point, any questions about this local optional scope?
Yes, Steve.
Jeff, sir.
Yeah, I just want to take a moment and again recognize and thank the agency and specifically Dr. Burley and yourself, Steve, for your collaboration on this project and getting this pushed to MDAC for approval. Once approved, this will align with Santa Cruz County as well as Santa Clara County, and once policies are implemented, it will make it much more seamless in supporting our flight paramedics to assist our flight nurses and make it much better for them to be able to work, across county lines and throughout the region from different bases without the concern of, which base that they're deploying from the particular day. So again, just thank you for your support, and we look forward to moving forward with this.
You're welcome.
Thank you, Jeff.
Thank you.
Okay, so let's move on to the next item, which is blood and blood product transfusion monitoring, and Deborah has something for that.
So this is sort of an adjunct that came about as a continuation of the CCT memo that Steve was referring to earlier. So an acknowledgement of the limited CCT resources within the county. And then the challenges sometimes for a sending facility to send a nurse along to accompany the patient. So when looking at the set of patients who may need CCT transports, one of the things that kind of popped out was that there's a subset of sick trauma patients who through EMS or private vehicle may arrive at a non-trauma center and then need to be transported to the trauma center. And one of the primary limitations on that patient going via ALS ambulance rather than or needing a nurse rather than going via ALS ambulance was the blood products. So in doing some research, we found that there were 6 LEMSAs throughout the state who have a LOSOP in place for paramedics to monitor previously established blood and blood product transfusions during interfacility transfers. So just to be clear, this doesn't allow the paramedics to establish or initiate those blood or blood products. So if you could go to the 3rd page. So we started working on a draft policy and algorithm to potentially apply for a LOSOP for this as well. This went to the CQI TAG and TQuIC committees yesterday for their feedback. We've gathered that and we'll work on incorporating the feedback into the documents that we've prepared. And we just wanted to present it to this group as well for any additional feedback that they may have.
Can you just scroll down a bit, just to give folks an
Do
opportunity
we
to see?
define further what blood products mean? Are we just gonna say blood products means?
Blood products would mean
pack cells,
pack cells,
cryo.
FFP, platelets, yeah, whatever you would normally use on mass transfusion protocol.
Can I ask one question that I didn't think of yesterday when we were discussing this? And that is, are we applying this to pediatrics as well?
It's a good question because we do have a pediatric mass transfusion protocol.
It would be 15 and up from our perspective for PD or for, I guess we consider 15 and up adult trauma within the county. I guess the question I would have is if a pediatric patient is going out and needs blood, should they stop by the trauma center first before going, or could the air ambulance give them blood on the way to the, I guess if they're needing blood, they're probably too unstable to leave the county to begin with. And they should probably go to the adult trauma center, get the blood, and then leave with a helicopter when stable.
Yeah, potentially. I guess my one concern here is if you have a very small child who needs a smaller volume than the entire bag, maybe they shouldn't be transported by a medic. Maybe they do need to go with a nurse, just because volume wise for peds, it may not be equal.
Well, 10 mils per kilo, so 20,
Yeah.
was it 250 in a blood bag? So 25 kilo kid would get a standard unit.
Right. So
We could just
you
put
know,
away a minimum weight on
that's
it.
what I was wondering. And if we are, I mean, I just think we need to define it if we're going to apply it to peds and make sure that we have appropriate cutoffs for where it wouldn't apply.
Great, thank you. We'll look at clarifying that in our policy. Okay, unless there are any other questions or comments, that brings us to MAC membership. And Deborah, you have a report on that.
Yes, there is an update included in your agenda packet. Dr. Kalinsky and Dr. Hawthorne have both been reappointed and agreed to join the MAC again for another term. Thank you for that. Dr. Cole Click has decided to move to an alternate position, and he's being replaced by Dr. Orchard, who has joined us today as well. Thank you both. And then since that memo was drafted, Dr. Greenson has also agreed to serve another term, and we'll be working on getting him additional information for that.
And he also nominated an alternate. We're trying to make sure that all the alternate positions are also filled. So now we're trying to make an effort to ask for somebody, for the member to nominate somebody as the alternate. I think that what we're waiting for is the nomination letter from the Law Enforcement Association to process the appointments for Chief Nieto and her alternate. And I think that takes care of all the memberships that are set to expire June 30th.
Thank you, Deborah. And then the last item on this portion of new business is EMS annual report. And I'll turn it over to you to begin, I guess.
Thank you. As with everything else, and I mentioned this earlier, that we have also taken a fresh look at our EMS annual report. And similar to our QI committees, we've done a sort of a reset and to try to take a look at our approach to the annual report in a different way. So some of the things that we've done is, first, we changed the reporting period from a fiscal year to a calendar year. And we used to, when we reported on a fiscal year, we used to report in the month of December, to the committees in the month of November. Now we are reporting on a calendar year, and we are reporting to the committees in May, which, it seemed the right thing to align it with EMS week being in the month of May. We also want the report to speak to a broader audience. We want people who may not always be so embedded into what we do to understand, have at least a basic understanding of what we do. So part of what you'll see with this annual report is a little bit more description as to what, like the clinical programs, the why, and why we do what we do. I think that if you have read the report, that I think that all of us should be very proud of the work that was done, because despite all the challenges that we faced in 2020, we did accomplish a lot. And I think that you can also see that now how we are working, and really the wheels may not be turning as fast as we want them to turn, but they are turning for us to move the system forward. So I hope that the annual report does reflect those things, that, you notice those. And we want to thank all of our stakeholders and the committee members for your valuable contribution to our system, because, without you, we don't do this alone. So thank you for that.
Thank you, Teresa. And I would just echo what Teresa's already said. It was a very interesting year, and with challenges that we didn't anticipate on January 1 of 2020. And so, it was a learning opportunity for the agency to go through something like that. It was a learning opportunity probably for all of us. And we really just appreciate, partnering with all of you, and getting through this and kind of coming out on the other side, having gained some experience and have had some success in navigating the COVID-19 pandemic, but also other challenges that the county faced. We had a pretty bad fire season last year. And so that came with its own challenges. We had some local flash flooding. We had to address the opioid epidemic. And so the agency was able to come to the table and address those things, but only by partnering with all of the other resources and specialists in the county. And so, we really take our hats off to each and every one of you guys for helping us with that process. It was not something that we did in a vacuum, and we really appreciate that partnership. And we look forward to continuing that in the upcoming year, and continuing to strengthen those relationships, because that's really what makes this system work. And so thank you again for all that you do.
And I want to thank the team. I know sometimes we don't say it enough. So thank you, Dr. Burley, because, it is thanks to your guidance that a lot of these things are moving forward. Thank you to the team. I think we have been put together a very strong team that, and it shows in all of the things that we have accomplished. So thank you for everything that you guys do. I really appreciate it. You too? Okay.
All right, well, thank you, Teresa. We'll go ahead and move on to the next item on the agenda, which is EMS System Quality Improvement Program, and specifically for CQI TAG. Deborah has a report for us.
So yesterday we held meetings with both our CQI TAG and our trauma quality improvement groups. Our next stroke and STEMI meetings are scheduled for June. We do need to look at modifying those times based on some conflicts with the state stroke and STEMI conferences. So we will be sending out some updates for that. I just want to hit some highlights of some sort of big picture projects that we're working on throughout those groups. The first one being that we're undertaking an effort to standardize trauma patient documentation. So we'll be working with members of the various EMS agencies throughout the county and a representative from the trauma program at Natividad to work on standardizing the data points so that we can more accurately and more easily pull data out of the PCRs to do a better and more thorough analysis of those. SVMH has also undertaken an effort to provide patient outcome and follow-up data through ESO directly. So they're currently working on that process. Our hope, we're working with them on that as well. And our hope would be to be able to use a similar process to provide some more data through Natividad and CHOMP as well, so we can kind of get a standardized set of data that's flowing from the hospitals to the EMS providers throughout the county. On the outcome and follow-up side, we're also, as Teresa mentioned, working on the AHA Get With The Guidelines for STEMI and stroke data, working on CARES for cardiac arrest registry data, and then we're still continuing to work through progress on the EMS agency having access to Trauma One directly for trauma patient follow-up as well. That's hit some IT snags that seem to hopefully be shaking out at this point. So we're also working with our epidemiologist and within the analysts to update our data that we're looking at for both trauma, STEMI, and stroke patients. So the trauma patient data has been revised, and we're continuing to work on the STEMI and stroke. We had a pretty robust discussion at the meetings yesterday, so that data will be going out via email. And if you have any feedback or follow-up on that, or things that you might find more useful to look at in the future, definitely be open to that. That's everything.
Okay, thank you, Deborah. Appreciate that. So that brings us to future items for the agenda, and like to open up to the group for any future agenda items that you'd like to see visited at MAC.
Yeah, it's Michelle Kalinsky. I would say, I thought about it after yesterday's discussion, and I think we need to do a minor revision to the trauma destination policy and require base contact for anybody over 15 that they're planning to fly out of county, so that we don't have another issue where we could have appropriately provided care and we sent somebody to a tertiary center and delayed interventions that were important. I think that's something that just should be base to fly.
Okay, thank you, Dr. Kalinsky. We can add that as an agenda item for our next MAC meeting. Any other future agenda items?
Dave Craddock here with one.
Go ahead, Dave.
I was approached by one of our younger paramedics at the department, and they were noting when we were doing our IGEL training for peds that the pediatric airway policy doesn't necessarily match the adult airway policy as far as like when to proceed to LMA. And they were just asking if we could maybe include that into a future revision and make guidance for the new folks a little bit more clear. That's all I have there, because it doesn't, if you compare them where it says, go to intubation on the adult, there's no box in the pediatric, and some of the new folks are a little concerned about that.
We'll take a look at that. You have that.
Yeah, we're already working on that. Thank you.
Any other future agenda items? Okay, and then that brings us to announcements for the good of the order. Any specific announcements from the group or items for good of the order? Okay, well, thank you all. And with 2 minutes to spare, I guess that brings us to the end of our meeting here. And just wanted to point out that our next meeting date is set for Wednesday, July 14th of this year, 8:30 a.m. Most likely will be a combination of on-site and Zoom, as we've been doing. With that, we'll go ahead and adjourn the meeting. So thank you all for coming. Oh,
I think there's somebody.
question?
Dr. Click has something.
Dr. Click, sorry, you had something?
I just wanted to thank everybody for my time on the committee. I enjoyed getting to know everybody, and I think especially in the last 12 months, it's been fun to watch the county EMS agency grow, and we're doing a lot of things in the county that I don't think we were doing when I first started out on the committee. So it's been fun to be a part of that. And I look forward to working with everybody just in different roles. I'll still be on TQuick, and I think you're in good hands having Dr. Orchard on the committee. So thank you, and I hope everybody does well.
Thank you, Dr. Click, for your contribution. I apologize because, I know you're still an alternate, so I didn't, I failed to say something earlier and just recognize your contribution to the committee. I know that you will still be an alternate in TQuick, but yeah, we should have.
Yeah, and again, so sorry, I should have commented as well. Thank you, Cole, for your comments. I'm kind of sad that you're going to be not a primary on MAC, because it's a joy having you here, and looking forward to continuing to work with you on TQuick. But I am sure we're in good hands with Dr. Orchard as well. So look forward to him joining the group. But thank and welcome to Dr. Orchard to MAC. We look forward to working with you. Thank you, Cole, for your contributions. Okay, well, thank you all, and we'll go ahead and adjourn the meeting, and we'll see many of you back for EMCC in a short while.